Hey there, Salim Razaya here. Welcome back to another Walking the Line from Research to Practice. And the trial we're going to be talking about today is the COCA trial, which is calcium in out-of-hospital cardiac arrest. Now, why are we talking about this? So we know that calcium from a physiologic standpoint is a great inotrope and vasopressor. There's very conflicting evidence prior to this study that tells us maybe we should or shouldn't use calcium. So we don't have any definitive evidence base or study or research to kind of tell us one way or the other. And then finally, it's in the ACLS guidelines. We all give calcium to these patients that come in with out-of-hospital cardiac arrest. So the clinical question these authors were trying to answer is, does administration of calcium during out-of-hospital cardiac arrest improve sustained return of spontaneous circulation? So these are out-of-hospital cardiac arrest patients and they get randomized to calcium or saline. The primary outcome, as we already talked about, was sustained return of spontaneous circulation, but they also had two very important secondary outcomes, which include survival and survival with good neurologic outcome, which they defined as a modified Rankin score of 0 to 3, 0 being no deficits, and 3 being able to perform activities of daily living with a little bit of assistance. 390 patients got recruited. What's interesting is that the majority of these patients had non-shockable rhythms. We'll come back to that when we talk about limitations. And then the response time was pretty quick for the system that we had this study from. Median time from cardiac arrest to meds was about 18 minutes. So here we have our primary and secondary outcomes and then randomized to calcium or saline. And what we can see is that there are trends toward calcium not doing as good as saline, which is kind of surprising for a lot of people, including myself. Now, it's important to note here that none of these results were statistically significant. The study just was not powered well enough. We'll talk about that in limitations. But again, there were numeric trends that should make us question whether we should be using calcium in an unselected group of out-of-hospital cardiac arrest patients. So some good things about this study is that there was no loss to follow-up. So everybody who got randomized had full follow-up. So we have full results for the primary outcome. Anytime you talk about any type of study that responds to critical patients, you want to know, are these patients balanced between groups before the study ever started? And the answer is yes. These patients were similar in terms of shockable rhythms, response time, CPR quality, all of the above. And anytime you look at out-of-hospital cardiac arrest studies, one thing we should all be looking for is what was the quality of the CPR? Because we know that the two things that make the biggest difference for these patients for survival with good neurologic outcome are high-quality CPR with minimal pauses and early defibrillation in the patients who qualify. Now, 65% of the patients in this cohort ended up having CPR quality data, and I can tell you going through those numbers, it looks like this pre-hospital system was very efficient and also very effective in the way that they were doing their CPR. In terms of weaknesses of the study, the trial got stopped early because of the COVID-19 pandemic. And so it may be that the study just wasn't powered correctly. And because of how sick these patients were, we're going to end up being closer to the null hypothesis. In other words, we were never going to see a benefit anyways. This could just be random chance. It could be the fact that they didn't fully recruit. The second issue is that they excluded patients with hyperkalemia, which to me seems like a no-brainer. These patients, we know that cardiac membrane stabilization, the treatment of choice, is going to be calcium. And then I already said that they had a low rate of shockable rhythms. Anytime you have a low rate of shockable rhythms, it could be that this patient population was so sick. We know with non-shockable rhythms that prognosis is not going to be as good as with shockable rhythms. And so it may be that many of these patients were going to survive anyways. In other words, the cohort was too sick to show any benefit of calcium. Now, there's three scenarios that I think that calcium still plays a role in out-of-hospital cardiac arrest given this new evidence. Patients with hyperkalemia, patients with hypocalcemia, which is not something that you're going to be able to test for. It's usually something you're going to get historically or from previous visits or some medication that they're on. And then finally, calcium channel blocker toxicity. We know one of the treatments is saturating all those calcium receptors with calcium. So here's three patients with cardiac arrest, or three types of patients where I think calcium would be beneficial. So as always, the bottom line. So IV or IO calcium in unselected patients with out-of-hospital cardiac arrest did not equal more sustained ROSC. As a matter of fact, there was potential for more harm from a numeric standpoint, but again, the study wasn't powered right to be statistically significant. I do think, however, in select patients such as hyperkalemia, hypocalcemia, calcium channel blocker toxicity, in these patients who are coding, there is still a role for calcium. And there you have it, walking the line from research to practice, the COCA trial. Please leave me your thoughts and comments, and until next time.